Welcome to episode 6 of the Pro PA podcast. I'm your host, Prof G, and today we're continuing our pulmonary infectious disorders series straight from the PANCE blueprint, and the topic is acute bronchitis. This is one of the most common respiratory conditions you'll see in outpatient and urgent care settings, so let's make sure you're ready to master it. Let's start with the kinder patho. What is acute bronchitis? Acute bronchitis is inflammation of the bronchi, which are the larger airways in the respiratory system. This is caused most often by a viral infection. In fact, greater than 90% of the time, a virus is the culprit. And I like to describe it as a temporary bronchial irritation. It's like the lungs' airways are inflamed, but the lung tissue is not infected, like with pneumonia. Important distinction. So, acute bronchitis is self limited and caused by infection, which is usually viral, and this is not the same as chronic bronchitis, which is part of COPD and is characterized by chronic productive cough lasting more than 3 months per year at least 2 consecutive years due to long term airway inflammation. So, important distinction, acute bronchitis is not the same as chronic bronchitis in COPD. The inflammation in acute bronchitis tends to lead to mucus production and airway irritation, resulting in a cough, and a cough is the predominant symptom. Now, who does it most often affect? Anyone can get acute bronchitis, but it's most common in adults and in children with recent upper respiratory infections or URIs. It can also happen more often in smokers or those who are exposed to lung irritants. And just like in acute bronchiolitis, we see that there is some seasonality to acute bronchitis, whereas cases tend to spike in the fall and winter months, especially during cold and flu season. So, how do these patients present? The symptoms of acute bronchitis are most commonly persistent cough. A lot of times, this cough can be productive, sometimes it can be non productive, but it's usually lasting around 5 or more days, typically lasts less than 3 weeks. So, it's still acute. Other symptoms that patients might present with are mild dyspnea or even some wheezing. They can also have some low grade fever, and it usually occurs kind of early on in the process, but having fever and especially high fever is not common. Patients often complain of some chest discomfort, and this is usually due to frequent coughing. And it's important to note that acute bronchitis is actually the most common cause of minor hemoptysis or blood in the sputum. What can we expect to find on physical exam? Well, acute bronchitis patients usually elicit some wheezing and rhonchi on auscultation, which can sometimes improve if you have the patient cough. They also should have fairly normal vital signs, and especially shouldn't have any signs of systemic illness like tachypnea, hypoxia, high fever. If we see those abnormal vital signs, we should start thinking it might not just be acute bronchitis. So, how do we work up patients with acute bronchitis? Well, like many other disorders, it is a clinical diagnosis. And it is also important to note that acute bronchitis is a diagnosis of exclusion. So, the key steps when approaching the diagnosis of acute bronchitis are one, to rule out pneumonia. Okay, you definitely don't want to misdiagnose a pneumonia as an acute bronchitis. So, you want to make sure that you have no focal lung findings on exam, no tachypnea, no hypoxia, no other signs that this could be something more than just acute bronchitis. You also do not need to get a chest x ray in every single patient that you suspect of having acute bronchitis, but you should consider a chest x ray if your patient has abnormal vital signs like the same things tachypnea, hypoxia, super high fever. Also, if on your physical exam you hear or see or feel signs of a consolidation on physical exam, you should definitely get a chest x-ray. And you should always get a chest x-ray in high-risk populations like the very young, the very old, and the immunocompromised. Let me give you a little pearl here. If a patient has a cough and normal vital signs, it's most likely not pneumonia. So it's probably acute bronchitis. and it's actually a really common thing that you'll see quite often and diagnose in the urgent care clinic or in your primary care peds clinic. So, how do we manage acute bronchitis? Well, the vast majority of cases, we are just going to provide supportive care. This is the mainstay of treatment. So, supportive care has a gamut of different things in our arsenal that we can prescribe or advise our patients to take. One is an antitussive like dextromethorphan, and this is really good, especially for nighttime cough relief, which is when symptoms tend to flare up the worst. We can also recommend our patients take expectorants like guaifenesin. This can help thin the mucus and make it easier to cough up the phlegm. We also should always advise our patients to have adequate hydration, maybe even more than they think, and to get plenty of rest. And we should be leery of prescribing cough medications with codeine components in them or narcotic cough medication because of the risk of dependency or misuse. We should avoid antibiotics. Acute bronchitis, like I mentioned before, is viral in greater than 90% of cases, and antibiotics are not indicated for viral infections, like we know. So, overprescribing antibiotics can increase resistance and risk side effects. So, don't do it. It is something that is done with a lot of frequency, but textbook says don't do it. Sometimes, in certain cases, we can prescribe a bronchodilator, and this can be trialed in patients that have more so than not wheezing or underlying reactive airway disease. Like every time they get an upper respiratory infection, they tend to get a little bit of wheezing or trouble breathing. But overall, bronchodilators are not often or routinely required. So let's talk a little bit about the book med versus the street med. So book med says acute bronchitis is viral, don't prescribe antibiotics. Okay. Street med. In real practice, in the ER and urgent care, patients are super demanding when it comes to antibiotics. I'm not saying to give in all cases, but it is a really important thing to do. Educate them on the viral nature of the illness and focus on symptom relief instead. Also, sometimes providers prescribe burst treatment of oral steroids or albuterol inhalers for acute bronchitis, and a lot of them do end up getting chest x-rays in the emergency room. So just be aware that that is kind of the norm of practice on the street. But in BookMed, definitely follow what we've talked about throughout this presentation. So some quick clinical pearls. Coughing. Number one symptom that's displayed for acute bronchitis. It usually lasts more than about 5 days in the absence of fever, tachypnea, abnormal lung sounds, and this is acute bronchitis. If wheezing is present, bronchodilators can help, but this is not asthma or COPD, so be cautious with overprescribing these medications. Antibiotics are rarely indicated. Save them for the cases with clear bacterial evidence or concern for pneumonia. All right, now that we've covered that, let's get into some quick review questions. I got a couple for you here. The first question is a 32-year-old, otherwise healthy male who presents with a persistent cough for 7 days. He denies fever, chills, no shortness of breath, and on exam, you hear scattered wheezing that clears with coughing. Vital signs are all normal. What is the most appropriate management? Is it A, azithromycin, B, bronchodilators and supportive care, C, chest x-ray, or D, doxycycline? I'll give you a sec. If you answered B, bronchodilators and supportive care, you're correct. The patient history and exam are consistent with acute bronchitis. Remember, antibiotics are not indicated, and supportive care plus or minus bronchodilators for wheezing are the appropriate management. All right, question number 2. A 56-year-old smoker presents with a 10-day history of productive cough and mild wheezing. He denies fever or significant shortness of breath, and on exam, vital signs are normal and rhonchi are heard that improve with coughing. What finding would prompt further evaluation for pneumonia in this patient? Is it A, a cough duration greater than 7 days? B, normal lung exam? C, hypoxia and tachypnea? Or D, mild wheezing? Let me know what you think. So the correct answer here is C, hypoxia and tachypnea. So hypoxia, tachypnea, or focal lung findings would suggest pneumonia, and this would warrant a further evaluation with a chest x-ray. So make sure that you pay attention to the vignette, make sure you pay attention to the patient's past medical history if they provide it, and put those pieces together to decide what's best. All right, well, thank you for joining me on today's clinical medicine brief on acute bronchitis. Remember, acute bronchitis is not the same as chronic bronchitis and COPD. It's self-limited, viral, and rarely requires antibiotics. Focus on supportive care and patient education to help manage this common condition effectively. For more in-depth pulmonary topics, check out my pulmonary module on YouTube on my channel, Professor G PAC. And if you found this episode helpful, keep an ear out for our next episode in the Pulmonary Infectious Disorders series. And don't forget to hit follow and turn on notifications so you'll never miss a new episode. As always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.